Hello everyone. In this class, we'll learn about mechanism of breathing. Mechanism of breathing or ventilation. Eupnea is rhythmic breathing at rest consists of inspiration and expiration. Inspiration, it is an active process during which the contraction of the respiratory muscle increases the intrathoracic volume. The intrapleural pressure at the base of the lung is normally about minus 2.5 mm of Hg, that is relative to atmospheric pressure, and which is at the start of inspiration, and it decreases to about minus 6 mm of Hg. Thus, lungs are pulled into a more expanded position, making the pressure in the airways slightly negative and air flows into the lung. The movement of diaphragm accounts for 75% of the change in the intrathoracic volume during quiet inspiration. The other inspiratory muscles are external intercostal muscles, which run obliquely downward and forward from the rib to rib. The ribs pivot as if hinged at the back, so that when the external intercostal contract, they elevate the lower ribs, which pushes the sternum outward, causing an increased anteroposterior diameter of the chest. Inspiratory mechanism. During inspiration, the thorax is enlarged because of the rib movements, that is, movement of the ribs outwards and upwards, and the diaphragmatic movements, that is, the descent of diaphragm. Rib movements, they can be pump handle movements. The second and sixth ribs slope obliquely towards and forwards from their joints with the spinal column. On inspiration, the ribs move upwards, pushing the sternum more anteriorly, which is called as pump handle movement, to assume a more horizontal position by contraction of external intercostals, resulting in increased AP diameter of the chest. And bucket handle movement is where there is the lower ribs, that is 7th to 10th, also swing outwards and upwards in inspiration, causing increase in the transverse diameter of the thorax. So these are the pump handle movements which occurs uh, because of the movement of the sternum. Okay, so here you can see the sternum. Uh, it when muscle contracts, they are going to uh, move in upward direction like this. And these are bucket handle movements. These are the movement of the thoracic rib cage, especially of the lower part of the rib cage. And when the ribs get elevated like this, there will be change in the transverse diameter. Whereas the pump handle movements, they are going to increase the anteroposterior diameter of the chest. Accessory muscles, scalene, sternocleidomastoid, they are active during voluntary static inspiratory effort that help to elevate the thoracic cage during deep inspiration. Intrinsic muscles of larynx, the abductor muscles of vocal cords, which are posterior cricothyroid, that contract early on inspiratory phase, pulling the vocal cords apart, opening the glottis. Expiratory mechanism. Quiet expiration is a passive process, but during forced expiration, example during exercise, bronchial asthma, the muscles of expiration contract. Expiratory muscles are the anterior abdominal muscles, that is abdominal recti, transverse abdominis, internal and external oblique muscles, and of course internal intercostal muscles. And accessory muscles of expiration are adductor muscles of the vocal cord. Pressure changes during ventilation. The intrapulmonary pressure and intraalveolar pressures. Intrapulmonary pressure is defined as the pressure in the lung parenchyma. It reduces with expansion of the lungs and facilitates the pull of air into the lungs via tracheobronchial tree. In quiet breathing, at the end of expiration and end inspiration, as no air going in and coming out of the lungs, the intrapleural pressure is equal to atmospheric pressure, that is around 760 mm of Hg. With the beginning of inspiration, as the volume increases, pressure decreases and intrapulmonary pressure decreases to approximately 3 mmHg below the atmospheric pressure, but regains the pressure value at the end of inspiration. As the expiration follows passively, the elastic recoil of the lungs causes intrapulmonary pressure to swing to the positive side, that is plus 3 mm of Hg, that is 763 mm of Hg. Factors which are affecting intrapulmonary pressure: Valsalva maneuver. Forced expiration against closed glottis may produce a positive intrapulmonary pressure of 100 mm of Hg above the atmospheric pressure. Muller's maneuver is a forced inspiration against a closed glottis and can reduce the intrapulmonary pressure to 80 mm of Hg below the atmospheric pressure. Intrapleural pressure. The pressure in the space between lungs and the chest wall, that is the intrapleural space, is called as intrapleural pressure. This pressure is subatmospheric and is not uniform throughout the thoracic cavity due to the effect of gravity. It is minus 2 mmHg at the base and minus 7 mmHg at the apex. The negative intrapleural pressure is directly proportional to the amount of thoracic expansion. Therefore, during quiet inspiration, the lungs are pulled into a more expanded position, causing intrapleural pressure to decrease to about minus 6 mm of Hg. At the end of inspiration, the muscles of inspiration relax and the intrapleural pressure becomes less negative and the lungs recoil, thereby intrapulmonary pressure increases. The factors which are affecting intrapleural pressure: deep inspiration decreases it as much as 30 mm of Hg to subatmospheric pressure. Effect of gravity: the intrapleural pressure in standing position is more negative at the apices of the lungs compared to the base. At the apices it is minus 7 mm of Hg and at the base it is minus 2 mm of Hg. Transpulmonary pressure: it is the difference between the alveolar pressure and the pleural pressure. It is the pressure difference between the pressure in the alveoli and that on the outer surfaces of the lungs. It is a measure of elastic forces of the lungs that tend to collapse the lungs at each instant of respiration, called recoil pressure. So this is the diagram showing the intrapulmonary pressure and intrapleural pressure. During inspiration in the alveoli, the pressure is going to decrease, and at the end of inspiration it becomes again atmospheric, and during the expiration again the pressure is going to increase, and again at the end of expiration the pressure becomes atmospheric. But in the intrapleural pressure is going to become more negative during inspiration and it reaches minus 6 mmHg at the end of inspiration, and again during expiration the intrapleural pressure becomes less negative, and at the end of expiration again it reaches to minus 2 mm of Hg. Clinical significance: since transmural pressure, that is the pressure gradient between intrapulmonary and intrapleural pressure, is less at bases, therefore lungs are less expanded at the bases. Emphysema, that is the loss of decrease in the lung elasticity, which increases the intrapleural pressure, thereby chest expands and becomes barrel shape. Injury to the thorax causes entry of air between two layers of pleura. Therefore, intrapleural pressure is equal to atmospheric pressure, thereby lung collapses, that which occurs in pneumothorax. So this is in brief about the mechanics of breathing. Thank you.